Hi, I'm Ruth, a GI medical oncologist at the Columbia University, and we're here at GI Oncology Now, ASCO 2025. And Mark, please introduce yourself.
Hi, I'm Mark Yarchoan. I'm a medical oncologist at Johns Hopkins in Baltimore, Maryland.
James Harding, medical oncologist, gastrointestinal oncology at Memorial Sloan Kettering Cancer Center.
Hi, I'm Namrata Vijayvergia. I am a GI medical oncologist at Fox Chase Cancer Center in Philadelphia.
With the most recent approval of nivolumab and ipilimumab, now we have increased number of choices as a frontline therapy for advanced stage HCC. And so now, how do you select treatment, and what's your number one choice, and what type of patient you have in mind for each regimen? Mark, do you want to share your experience?
Yeah, I mean, it's an exciting time for all of us, I think. I mean, I remember when I graduated from fellowship and all we had was sorafenib with a 2 to 3 month OS prolongation, and now we have this incredible menu of new options, and I think the challenges, none of them have really been compared head to head, and so we don't really know what to use for what patient. The 3 approved options are Ipi-Nivo, Atezo Bev, and durva treme. I think we're sort of stuck looking across the trials to draw some sort of conclusions, and I think obviously there's a group of patients who are ineligible for anti-VEGF therapy, and I think for those patients, IO doublets remain preferred. But there's a large group of patients that I think are candidates for all of these therapies. And I think when we look across the data, the IO doublets, clearly, if you respond to these doublets, you respond for a really long time. So I think the strength of these regimens is the tail on the curve that we keep seeing. But I think Atezo Bev is compelling in that it has a higher stable disease rate, and so patients do well, not just in the long term, but also in the short run, which is why many of us have sort of continuing to use it as a preferred option. I think the Ipi-Nivo approval is new, and we're still trying to figure out where it fits in the treatment algorithm. So I don't know if you want to add some thoughts.
I would echo what you said. This is a truly exciting time. I think the Checkmate 90W data were in another example of how CTLA-4 blockade may have impact in this disease. Clearly from that study, you see really improvement in overall survival. Too early to look at the tail, but the 2-year landmark was certainly compelling. I think another aspect of the study that was important to note is that Ipi-3 Nivo 1 is what was used in this study based on a prior phase 1/2 that looked at various dosing schedules. So most oncologists are familiar with different dosing schedules of ipilimumab. The Ipi-3, I do think, has a potency to it and a potent immune activator. So in that regimen, you have to be mindful of the potential of immune-related adverse events.
Absolutely. I think using the Ipi-3 and Nivo 1 and earlier studies for even colon cancer, when we initially did the studies, we definitely saw higher rates of IRAEs and more potent IRAEs in the beginning. Compared to that, I always wonder if the STRIDE regimen, right, which was the durva treme, the single dose treme, but again, I think the Ipi-Nivo data and the 2-year survival of it is pretty exciting, in my opinion, too. The Atezo Bev, obviously, as it's probably least toxic of the all group in an all-comer population if you don't have a specific adverse reason to avoid bevacizumab. So majority in the community, I think Atezo Bev still remains the frontline choice for most people. There's no head-to-head comparison, but I really think the dual IO combinations are definitely something that we discuss with patients every time, and many patients actually want that.
Since we're talking about adverse events, I know we're not supposed to do cross-trial comparison, but there are different regimens. When you look at the adverse events profile from each study, or things like patient characteristics you're looking at, do you have any sort of, what's your opinion about selecting any treatment based on adverse events?
Well, so I think from IMbrave 150, it's always good to look at the history. So there was an initial phase 2 study that was conducted actually out of Columbia, led by a prior faculty there, essentially indicating that without assuring that there is not a risk of bleeding, there was actually a high rate of GI hemorrhage. And the study was held, amended such that endoscopy was required, and there in the advanced setting you were able to see some single agent activity with tolerability. So I'd say the IMbrave 150 data really show that the risk of profile could be hemorrhaging. Mostly it's epistaxis, but there were some grade 3 through 5 events related to bleeding. So in this regimen, we are often working closely with hepatologists and gastroenterologists to assure that an EGD is completed and to adjudicate a potential bleeding risk. I also think that other toxicities could be, hypertension related to the regimen, proteinuria, timing related to surgery. But in general, the IMbrave 150 has been tolerable and, of course, extends survival, which is different than the immune doublets. I don't know if anyone else would like to comment.
No. Oh, yeah. So I think on the contrary, right, we know with the immune doublets, you are in the water for the first 3 months, right? There was data presented from the STRIDE regimen study as well, from that most of the immune-related side effects happen in the beginning, so you can predict and preemptively watch for side effects more carefully, which allows, like I tell patients all the time, that this is the time, the first, we are going to watch you like a hawk, and if you cross that initial path, most likely you're going to be fine for the rest of it, which is slightly different than BEV. Bleeding can happen later down the road too, and issues that come with it.
And, I think, again, you said we can't do cross-trial comparisons, and I agree, but at the end of the day, when you have a patient in front of you, you have to choose a regimen, and what else can we really do? I think Ipi-Nivo, clearly with the Ipi-3 dose that is approved, it's a very high functionally CTLA-4 dose, and, with that dose, comes a high response rate. I think the response rate is impressive, 36%. I think that's often been the criticism with the STRIDE regimen, is the response rate of 20%. But with that higher response rate does appear to come potentially more toxicity. And so, I wouldn't say that we know which patient should get what, but I would be hesitant to give Ipi-Nivo to, a patient who really was not very fit. I think we have to be mindful of that. That said, if you really need a response, I'm not sure that I would reach for durva treme. I think those are patients where you don't immediately need a response and they're only going to get to one line of therapy. That's my philosophy. I don't know if you guys agree with that.
I agree with we need to really watch patients closely in the first 3 months, but we also need to keep in mind that immune-mediated AEs can occur even when you stop therapy. So I always keep it on the differential diagnosis when patients get in trouble.